Okay, so I just wanted to let you know that with all this said, and you deciding on your own level of participation, this is going to be interactive and it is recorded. So I also want to do within this topic, because it's so personal, that we always talk from our perspective of what I want for myself. There are a lot of educators and a lot of information we know out there, and I so appreciate that, and I want us to share because I'm still continuing to learn from everybody else and everybody's experiences. But just be sensitive when people are asking for advice or questions that you're just coming from your own experiences and so on. So I just kind of wanted to share that as well. Just a little overview of what we're going to go over today. We're going to do some introductions. We're going to go over the advanced care planning and directive. Planning and directives I kind of put into one. There's really 6 components of advanced healthcare directive. That's some of you, when I was reading your feedback, you're all different levels of engagement around advanced care planning and directive. So I know that, thank you. It's people like haven't even considered it, to everybody's had it on board and know what they're going to do if COVID-19 comes to the door. Okay, so the people at all different levels of conversation around this. So we're going to discuss some more parts than others, but I want you to get a framework of what's part of advanced healthcare directive. Then I want to go more specifically into reviewing the Conversation Project, which now hosts National Healthcare Decision Day. It's just a really wonderful national platform. And they did a really great job of doing a 2-pager, which I sent to most of you yesterday, on conversations specifically around COVID-19 to consider. So I want us to review that as a group. And within that, it has more specific questions. Because it's not just about filling out the forms on the directives. It's really about identifying your values and what's important. So I think that's a good way of reviewing some of that together. There's tons of amazing resources out there. I was spending so much time today going, which ones should I share? Because there's so many good nuggets of information, but I'm going to try to, I have it all, but doesn't mean I throw it up all over you, but I have some of the amazing resources and kind of feeling through what is needed for yourself or others that you work with, or even for your own family. Okay, and then the reflections and conclusions. Does anybody have any questions, or does anybody want to do a little coffee break? I'm going to take a little coffee break right now. So I'm going to invite you all right now. Thank you so much for those that have already shared what music or musicians brings them comfort. We have a wide range here. As some of you already heard, mine was some binaural beats that bring some solace and calm to me at different times. So if you want to kind of read through theirs, didn't get Devore, what music brings you comfort? You got the Culver City, and then Christina, I want to feel most comfortable. I listen to some 70s rock, the music we listened to when I was younger and cleaning the house. Yeah, like to get you going, right? And that also, you said in the house, because it's the family. I mean, we used to listen to Motown, right? So I understand that. To be honest with you, that's a good one, because the music that brings me home is listening to the Big Chill soundtrack. Like my whole family listens to the Big Chill sound, and there's actually 2 volumes. So that's always a good one to kind of get the family together and all the same pages, listening to some of that. So that's a nice kind of communal piece. So thank you for kind of reflecting on that for me. But your mother, Supertramp or John Lennon. Okay, yeah, great. All right, beautiful. So we're going to go around right now. There are 9 of us. I wanted everybody to get a chance to speak, but I think right now I'm going to stick with the chat box, just so we can kind of, and what the questions are for the chat box is, I'm going to put this in here for you. Let me get this for you in a second. There it is. I'm going to put this in the chat box right now for you. Jack, I'm sorry that you're not able to get onto the chat box. It's like I said, it's usually on the bottom of your screen, and then there's a white box that comes up on the side, And then on the bottom, it says to and everyone, and then underneath it says type message here. And that's where you should put in your information, if that's what you see. If you don't, then I'm gonna have to go over it with you another time, okay? So the questions are that I have for all of you is, normally if it's a smaller group where we had more time, I would do this in person, because I think, like I said, even though this is all voluntary, people can share your name again. Why is this important to you? Why are you here? It could be short, it's time. If that's, where are you in the advanced care planning, and in the time of COVID-19 I'm feeling. So these are just some of the questions I wanted you to reflect on. If you want to respond to one of those in the chat box, you don't have to do it all over. We don't have time to go around the room right now and do it around the Zoom lens. But I guess right now I kind of know I have B and C for most of you right now. How are you feeling right now? Just give me 1 or 2 words in the chat box of how you're feeling right now. In the chat box, if you can just go to D. In the time of COVID-19, I'm feeling good. Lynn's feeling good. Learning. Yeah, Carol. The time of COVID-19, how are you feeling right now? If you want to add into the chat box. Yeah, Natalie, I'm training to become a death doula. During this time, I'm feeling a little uneasy, unsure, and antsy. Yeah, I think the idea of being part of community is important for these conversations. I'm constantly, updating the conversation for myself. What does it look like? What have you heard in the news? So usually when I talk to people about when to have this conversation, it's usually like, oh, if you saw a movie or a book or a documentary you like, well, then it's a good opportunity to start kind of conversations with families about, something happened. Well, we're living in this kind of society right now. So then it's also like, where do you start the conversation? Yeah. Concerned about my older father, Devora, who's in a facility and struggling with will to live. Yeah. The emotions and the courage right now and is hard. The emotionality, and we also know with immunity when you're feeling that perplexed. So yes, Devora, I'm sure. And then even communication has probably changed right now as well. Yeah. Thank you for sharing. All right, so thank you for sharing how you're feeling right now. Let's go into advanced healthcare directives and planning, okay? The way I like to do it is, and most of this, I sent you some information yesterday, but really this is just, I wanna give you an overview of advanced care planning, then we'll go into the specifics. Advanced care planning and directives is a part of a larger conversation about a comprehensive estate plan. And some people don't, in a comprehensive estate plan, it covers 4 things. You have your will, trust, power of attorney for finances, and an advanced healthcare directive, right? Usually people update this during certain times in their lives. If they get married, if they have children, if they retire, that's the big 4. Who do you have those conversations with? It just doesn't happen, right? Usually it's a lawyer that maybe will like, oh, I need to work on this, I'll write it up. Or you think you have to have a lot of money to do it. These are the 4 basics of a comprehensive estate plan. Usually you want to work with an elder law attorney or estate planner to do that. Now, when you do that, and we're here to specifically talk about the advanced healthcare directive, we need to dive a little deeper, and I know that's why you're all here. Those conversations potentially happen with your lawyer, and starting in the last few years with your healthcare system and doctor. Who here, if you can write in the chat box, has talked, or what healthcare system you're with that has updated or wants to know about your advanced healthcare directive? Has anybody had that conversation, or has it come up within your healthcare system? Because so many other things in our life that there's usually people we work with has never come up, right? Natalie, this advanced healthcare directive conversation has never come up. I don't know if you remember a few years ago, we had the conversation around the death panels that was like, oh, we can't have that because of the death panel. Like bringing up death is about the death panels. And, you know, that was a political, oh, wait, Christine, I'll get to you in a second. Or, oh, okay, no, okay. So now, a few years later in 2016, there is now a Medicare code to have advanced healthcare discussions. There's a code for a doctor for you to have this conversation. So this is for Medicare. And the best time to do that is when you're supposed to have your annual wellness checkup. This is the kind of thing that is never brought up. You usually have to be proactive, and Lynn knows this better than anybody because we have tons of tools on how to talk to your doctor. Ideally, it's not there yet unless you go into surgery of people asking, what are your hopes and wishes and who's going to speak for you when you can't speak for yourself? We're changing that, right? I know one of my uncle's favorite books, and mine too, is Being Mortar by Dr. Atul Gawande, that was out a few years ago. And that really was, with a lot of other things, shifting the conversation. Oh, I'll call you in a minute. Oh, admit. Thank you, Devora. Sorry about that. Thank you thanks, Devora, for letting me know Talia is coming on. So that's just some just general background that we don't really is shared, is where and how do we have these conversations unless there's individuals like us, right, Natalie? Like us that are like the guides and the doulas that are maybe outside the systems to do it. That is shifting now. Somebody says they're part of Kaiser, brought in my health, except Kaiser's banner and weight. Yes, Lynn, exactly. So Kaiser has a great model in starting these conversations. I mean, they're so good is that they have a social worker sitting within the care program for geriatrics. I've been starting to collect right now different healthcare systems and what kind of conversations they have around advanced care planning. Providence with the Institute of Caring is doing a good job. The UC systems are coming up. There are a ton of resources and pages, but it's hard to navigate to get to those conversations. There's certain centers like with the Alzheimer's Disease Resource Center at UCLA, they have now started that as part of their, once you're part of that program. But overall, when you turn 18, you should be having these conversations. So that's just a background of like, why don't we do this? Why is it so hard? Because it's not quite integrated into the system yet early on until there is a diagnosis. That is what we're trying to change, is bringing that conversation out and why you're here now and why it's National Healthcare Decision Day. Okay, so those are some just backgrounds of, you know, to give scope of, you know, it's just not integrated quite yet, but there are a lot of thought leaders and speakers and us talking about that. So that's just one thing. The other thing I wanted to talk about was what are the different components of the Advanced Healthcare Directive. One of the ones that we talk about the most is who's going to speak for me? Who is my decision maker? There's a lot of different names for that on different forms or how we talk. Some people call it an agent. Some people call it a healthcare proxy. Healthcare surrogate, durable power of attorney for healthcare. I'm really resonating right now with decision maker. You know, who's going to be my co-decision maker? And even at that, within some of these directives, you can decide when you want that person to start coming in and being your decision maker. If you're older and maybe have dementia, maybe you want that decision maker to start speaking on your behalf sooner than later. Usually it goes in when you can't speak for yourself. On certain directives, it asks you, certain people say, do you want this person to speak with you now or not? That's usually more at the end of life, you know, during comfort care, but you can bring that out sooner. And just for you that are working with others, that's always a conversation of who do you want to speak with you, or who do you want to speak with and for you at what point? So getting clarity around that. I know right now I want to speak for myself until you know, until I don't have the capacity to. For others are in different places in their life. For Devora, her dad's maybe at a different place right now. because of health and age and whatever. Okay, so just want to clarify that role with the agent, with the decision maker. The importance of a decision maker is because for a lot of people, the default, at least in California, it's not is kind of like your next of kin, and it's relational. It's more legal. So if you're married, then it goes to children, parents. They're going to look like who's your agent, and they go to next of kin. For many people now, it's a family of choice. It might not be a family member that really knows the wishes best. So you have to get that in writing. You know, I know right now I was working with somebody, you know, their neighbors know them better than anybody. So you really want to be sure. And there's a lot of different ways around this, and can be elder abuse and fraud with this. Let's get that out of the way of who do you want to speak for you for your health. Get it in writing. More importantly, have that communication. You know, even now, to be honest, I was reflecting on who do I want to have as my decision maker. If right now it's my parents, and would they be willing to take care of me, or if I'm not able to do certain things for myself, would they be able to make some of those calls? So I had to have that conversation with them again. Question, sorry, I'm going to stop here. Elizabeth had a question. Does it generally follow the same order of succession and inheritance? Here in California, it goes spouse, kids, parent, sibling. In DC, where I'm from, the inheritance with no siblings equals siblings first. You know, I don't know enough information about that. There are some legal channels that I can go to find out about that. There's an elder law attorney locally I have, and there's also the UCSF Hastings Center has a medical legal partnership program around advanced care planning. They have actually created a beautiful, very specific advanced healthcare directive for legal. But I'm sure those are the organizations that might have more information about the finances. Or you could also talk to the California Primary Primary Fiduciary Association. So Elizabeth, let's find out more about that, and we can do more details about what the parallel is. Lynn, do you have any more information on that with the finances? Do you know about the role?
I would just say that in the context of today, we're just talking about advanced healthcare directives.
Okay. But that's
I say see a lawyer.
Okay, got it. Yes.
And elder law, especially somebody who specializes in elder law, and also, you know, the local senior centers usually have some a legal clinic.
Great. So yeah, so that's a good, it's kind of, I like, Elizabeth, though, how you're thinking, the parallel of how's the best way to get information and to look at stuff. So I really appreciate that, especially for a lot of other of colleagues on this call. It's a good way of thinking. So thank you for that, Elizabeth. Some of the questions to think about for, oh, okay, no problem. No, Elizabeth, I understood you. It's great, thank you. But yeah, the next of kin. The other thing that's really important about filling out the advanced healthcare directive is what happens to your body afterwards. Who is responsible for it? Who's gonna say what you do or don't wanna do with it? I was at someone's home, and we were about to get him onto hospice, and he progressed, and he really wanted his friends to be his agents, and we were working on the paperwork. It was at that point that he already died, and we had to find his next of kin and find them, and he was abandoned from them, and they couldn't do anything with the body because they had to figure out. So there was a gap in time of knowing how the person wanted their body treated. So the advanced healthcare directive, and on there, in terms of having this person, having this agent or this decision maker also be responsible for what happens to you, to your body, the disposition after you die. So that's another reason to really focus on this, because then you get stuck in the system. And we don't have to go into that. okay, sorry. Are they assertive enough? So basically there's certain questions that you need to ask for yourself of why you chose this decision maker. So I'm going to do a group question right now. What is the most important thing you would want your decision maker, that you would want of your decision maker? Why did you choose that decision maker? I'm going to put this in the box. I'm going to put the question in the box and I'm going to have you answer this. Okay. What is the most important thing you would want from your decision maker? Like, what do you want them to know? I'm asking you right now. It's in the box. If you guys want to fill it in really quickly of what would you want? What do you want? Strong advocate who deeply understands my wishes. Yes, Devorah. You know, the care you want or don't want. Definitely. Assertive, clear on my wishes, not intimidated by physicians and others in white coats. Yes, Lynn. Lynn, I hope Lynn is a wonderful advocate. So I'm sure she has trained the others around her to be advocates for themselves and for her as well. Does anybody else have a thought on what's important for your decision makers to know for you? You know, for me, it's being able to be involved in my community, to engage in some way with my different senses. You know, that is one thing that's important to me. So, you know, try to be engaged as possible. I wrote on another, when I've been like journaling some of these things, another thing is to feel a value. You know, that's really personal too. And what does that mean to feel a value? So I need to kind of hash that out a little bit more. Devorah, can separate their emotions from what needs to happen. Yes, that is a great one. And that's why we always say in people in this world that it's a gift, right? To plan ahead and to tell individuals what you want or don't want, because when you're there, it's like they're honoring your wishes. They're speaking on behalf of you, then they're doing something to you or for you. So I think it's that really idea of having very clear, and doctors, you know, like you said, being very assertive and being advocate, because doctors, you want to partner with your doctors or, you know, to see what, you know, for me, it would be for if there is some question of to partner with my doctors, with the team to figure out what, if it meets my wishes, you know, to have some dialogue there. Okay, Elizabeth, thank you. Everything everyone else said, great. Okay, all right, so that's the directives. Is there any other questions or thoughts on who, you know, yes, Lynn, go for it.
When you were talking about disposition of the body, that goes along with whoever you've named to speak for you, doesn't it, in your advanced directive?
Exactly, but
okay.
If you don't have an advanced healthcare directive,
okay.
then that's another story. So it's just another reason that when I was talking, you know, to some friends, some colleagues that work for a funeral home or funeral director, that is something that they look at that's filled out. If not, they have to work with the county, or they need to work with you know, you have to work with a different body and not a family. So it can take very long and the body can get lost. I mean, it doesn't get physically lost, but you know, so that kind of thing. Does anybody have any other questions or comments on that? Okay, Devorah, good question with rewriting the advanced care directive. Are people rewriting advanced care directive now with COVID-19 specifics? Some are. We are going to, at the end of this, I have a sheet that I actually emailed to you as well that was more of a bird's eye view of advanced healthcare directive in time of COVID-19. So there are some individuals that are updating it. I think what it does is people are having the conversation now as they might be going to the doctors or about what they want or don't want, and that's when they will pull it out. But we are ahead of that, and I'll show you the document later. Okay, the next part of the part 2 of the healthcare directive is the instruction for healthcare. So the instruction for healthcare is also called different things depending on what directive you're looking at. Like I said, I have a lot of different resources of different advanced healthcare directives that I like for different populations, you know, for more detailed or not. but it could be called instruction for healthcare, advanced care planning decisions, prolonging or not prolonging life. These are some of the words that are very directed in part 2. So this is what is really the section that you can always add on to addendums of do not prolong life, and do not prolong life. And there's different aspects within that. I'm going to review some of that today. We're not going to go into details, but this section is really when you want to review your values, what's important to you, at what point. So I'm going to kind of briefly go over some of the wording on one of this. Like I said, some advanced healthcare directives get very specific on this. I'm going to do an overview and then talk about some of the treatments for that. So under choose not to prolong life, I do not want my life to be prolonged if I have an incurable and irreversible condition that would result in my death within a relatively short time. 2, I become unconscious and to a reasonable degree of medical certainty, I will not regain consciousness. Or 3, the likely risks and burdens of treatment would outweigh the expected benefits, and that's for choosing not to prolong life. Okay, so that's A. That's choose not to prolong life. This directive gave 3 different reasons. You can add, cross out, add, and then for choice to prolong life, I want my life to be prolonged as long as possible within the limits of generally accepted healthcare standards. Right? That's very broad, and I think that's kind of the default. The default is choose to prolong life. Now, within this choose to prolong and not to prolong, the different types of treatments that we're looking at, we talk about, this is where we talk about life support treatments. There's CPR, right? Cardiopulmonary resuscitation. And that's working on the hearts, the lungs to bring you back. This may involve pressing hard on your chest to keep your blood pumping, electrical shocks to jumpstart your heart, and medicines in your vein. So there's CPR, there's breathing machine or ventilator that we're hearing a lot about. We can go into that in a second. Dialysis, feeding tubes or artificial nutrition and hydration, blood transfusions, surgeries, medicines, and comfort care. Okay, so within this prolong, do not prolong, there's a list of other life-sustaining treatments that we can consider. Now, even within that, a lot of times there's what we call trial periods for certain ones of treatment. CPR is not a trial treatment, but so depending on your level of health at this time, and this is why to update it every so often, is how you would want to respond to each one of those. We know we've heard a lot about being intubated, what that looks like if you're vulnerable health-wise, and what that will look different for one person versus another, especially in time of COVID-19. It's really, and one person that's 75 is one person that's 75 in terms of health, or not. I mean, I heard there was someone who was 104 that walked out from COVID-19. So within that area of prolong, do not prolong, there's a level of different life-sustaining treatments that you can acknowledge and at what point do you want to extend it or not? Does anybody have any questions or clarity on that? I'm not going to go into details. If this is of interest, I can give you some. There's some wonderful other resources out there that go more into detail. The National Institute of Aging actually has a great detailed breakdown of all those different life-sustaining treatments that I really appreciated. The NIH. So I was really impressed by theirs. Is there anything? And I guess, is there any concerns or questions about any of those areas. Does this sound familiar to you? Is this, and I think this is where people want to get more detail, but really it's, and for me as well, it depends. But knowing it's in here and that it's not a default yes to everything right now for you is really important. And that's why when we talk about comfort care, and I'm just going to bring up this word of palliative care, right? Palliative care is an umbrella term to represent comfort care, pain management care, and really more about patient-centered. So if you're within a healthcare system, inpatient or outpatient, maybe that's something you can put in your directive. Seek palliative care support to really hone in on what kind of care you'd want or don't want. There's another conversation that Lynn and I would go into now about what are your different end-of-life options, but I'm going to put that on hold right now for maybe a little bit later because I want to get through the directive. But palliative care, really inpatient or outpatient, and this is really good, Devorah, for your question about during COVID-19, is seek out those resources, those individuals that are comfortable with this conversation. In the New York Times, and I'll send you this article again, there's a wonderful palliative care doctor. I actually have her book here. I'm doing a plug. Dr. Sunita Puri, who beautiful woman. She's doing a talk, I think either later today or tomorrow with Endwell Foundation is another organization, but I'll send you the article in New York Times. She's a palliative care doctor at USC, and what are the questions look like right now, and talk to a palliative care doctor. So I think that's another good response in terms of this time. Who are those resources that are more flexible to help you with that? Was there any more questions? Yes, Lynn.
I'd just like to comment, maybe this is the wrong place for it, but I think what a lot of people are struggling with right now is that their loved ones are in a skilled nursing facility or a memory care facility, and they cannot go and see them. And trying to figure out using a cell phone or FaceTime or something with their loved one and whoever their agent is and the doctor to clarify, if I get coronavirus, do I want to stay here? And if they say that, they cannot also be saying at the same time, I would want everything done.
Right. So there's a couple different things bringing it up, because we've known that there's some people that might have been in facilities, maybe that go home, that decide they don't want to stay in a certain hospital and want to, have comfort care at home, and not everything. So their communication is challenging. Acknowledging how to care with somebody when you can't physically be with them or even speak to them or see them definitely puts another barrier up. I have a friend that's going through this right now with her mother. Yeah, it's just very challenging times. And I guess there's very specific questions to ask the doctor or nurse in terms of that person's ability level right now, and what you know about their wishes.
Well, if I was in that situation, I would request a telemedicine visit with the doctor and me if I am now the decision maker. And if I'm not, and the person has a POLST already, I would request a 3-way meeting with all of us. I'd have to be on the phone or on FaceTime, and the doctor and my mother or father or whoever it was, and clarify, if I get coronavirus, do I want to go to the hospital and have everything done, or do I want to stay here and be comfortable?
Beautiful.
I think that's the direction the doctors and the staff are looking for.
That's the question, right? We'll go at the end of the COVID-19. I want to see if that's on the conversation project. I think on their sheet that they give. So I think these are great suggestions. Telehealth, it's been in the back burner for a while. Last 2 weeks, National Hospice and Palliative Care Association, along with many other organizations, telehealth has been a major issue. There's been policy updates and protocols set up for telehealth. It's like booming. So telehealth, palliative care doctors, and telehealth. those are the resources we have, along with that question that Lynn just posed. Lynn, can you put that question in the text box for me?
Yeah.
That's a wonderful question that, like, if you have somebody that's in a skilled nursing facility or assisted living, this is the question to ask. So thank you so much for that, Lynn. Okay. The next area of the Advanced Healthcare Directive is part 3 is donation of organs, tissues, and parts at death. I think it's very interesting that the DMV knows that I'm an organ donor, but nobody else does. Maybe people do because the sticker is on it. But we're not going to go into details about the organ donation. I do have some references of different organ donation locations, because some of that has to be pre-planned as well. If you want it to be for research, what parts of your body you want to donate. All this being said, when you fill out your Advanced Healthcare Directive, and I should have said that in the front end, is what do you want to do for your level of care with where you're at right now? It's not a what if, it's a right now. You know, so that is where you start your Advanced Healthcare Directive from, is where you're at right now. So right now, it could be, you know, in a random accident, or maybe COVID. Now that's why we're speeding this up a little bit, Devorah, right? This question of what if COVID-19, but it's within that we're talking about being on respirators and, you know, being intubated, but also about just general, I'm healthy, what would I want right now? So it's a kind of a twofold. Okay. Lynn's okay there. So Jack, good question. Does palliative care kick in when person decides against extreme measures? Actually, no. You do not have to have a terminal illness to be on palliative care. It's if you have a chronic or terminal illness. So it's for pain management. So you can have palliative inpatient, outpatient if you have a chronic or terminal illness. So it's not just, it's a lot of times it's related to hospice within, you know, when you're terminally ill, but it can upstart earlier because they really do an evaluation. So you do not have to have a terminal diagnosis to get palliative care. But that's a great clarity question. So thank you for that. So organ donation, it's something more to do some research on. And I know those are one of the first calls people get. Let's say if they're in a car accident, they're rushed in, there's people calling, and that's something to be aware of. People are calling in and saying, what would you like to do with your family member's body, tissues, organs, and so on. So we're not going to go into detail on that. Part 4 is primary physician. It's optional. So if you know your doctor, and once again, this Advanced Healthcare Directive, your advanced care planning is a team effort, right? You're talking about this, you're creating your team, you have your decision makers, which is family members, you have your primary physician, because they're really holding together the team. We know if you get a chronic or terminal illness, you get tons, like there's specialists in everything, right? The doctors that I've gotten along best with and that I used to love working with are the family physicians, because they're patient-centered still. They still want to get to know you. So if that is where it's rooted for you is, and that's optional in here, both the organ donation and primary physician information on your Advanced Healthcare Directive, this is 4 and 5, is optional. But for us that are all on this call, you need to be aware of it, and it's something that's probably important for you, for your own level of care and what, you know, how you want to be treated, and your team, right? And your team is your, you know, when people are talking about healthcare professionals now in the community, yes, it's doctors, nurses, but it's also social workers, it's all the therapists, it's the chaplains, it's like the volunteers are kind of at home right now, but it's a whole team of individuals, you know, that are there for you. Part 5 is the signature and witnessing. In California, and I don't know what it's like in Massachusetts or some other places, it does not need to be notarized, but you need 2 witnesses. The witnesses cannot be a decision maker, an agent, can't be a physician, and can't be a member of the facility that you're living in. So those are 3 do nots for people that were witnesses on your Advanced Healthcare Directive. All right. So that's signed and dated. You can update it. There's a lot of different addendums you can add. We'll go over some of those later. They're maybe not legally binding, but if it's in here, people are gonna relate to this. Okay. Part 5. And then part 6 is a special witness requirement if you're in a skilled nursing facility. Okay. So that's part 6. That's just to be aware of if that's where somebody's being moved into a facility. And that's really about kind of what Lynn was talking about, you know, the telehealth. Let's really talk about what's important to this person. I'm coming back to the Advanced Healthcare Directive. And at that point, I just want to share another another document. There's Advanced Healthcare Directive, and then there's also something called a POLST or MOLST, a physician order life-sustaining treatment. And that is used differently than an Advanced Healthcare Directive. If you're 18 and above, we should have an Advanced Healthcare Directive. I kind of wanted to start clubs on college campuses called, I forgot what I was going to call it. Darn it. I had a really great name for it at the time. It'll come back to me. But starting a club within the health, like a student union club that's maybe part of a health club or part of Hillel, because I'm involved in the Jewish community. Start a club to start advanced healthcare directives in these conversations, because really the conversation needs to start then. I also know some other doctors, instead of sex education, they do death education to start earlier, to acknowledge what's going on and filling out these directives. But going back to the POLST, it can actually be filled out by physician or nurse practitioner in California. And that is it's a hot pink form. How many of you are familiar with the POLST? Yeah. So just a quick review of it. It's a condensed version of a advanced healthcare directive that is extremely for those that are terminally ill, or that you think, and this is a guideline, will probably die within the year. So it's not everybody fill this out if you live in an assisted living facility or board and care. It's not, some people utilize it that way. It's really a very focused directive. And some people now with COVID-19 are like, I don't want to be resuscitated. How can I because the hot pink form on the door at home is really is one of the best ways not to get a CPR or do not resuscitate. But really you need to be in that situation. Terminally ill, less than a year. And those go very specifically, even more into the kind of treatment you want or don't want in terms of prolonging, not prolonging, feeding, stopping eating and drinking, more specifics. Oh, thanks, Lynn, for putting that comment in the post, in the chat box. Thank you. So the POLST is something that you can review, but usually it hopefully is before, like, once again, most doctors don't bring this up, like they don't bring up the Advanced Healthcare Directive. POLST, when it's more terminal, is even more challenging. Once again, I think things are changing with palliative care doctors coming in and palliative care teams coming in at the conversation, and us having those conversations sooner. So I just wanted to pause and acknowledge the POLST and how that's really the tried and true way. If somebody only wants comfort care for them, and if they get 911 call or a call at home, that hot pink form is do not, and it says, you click on the box, do not resuscitate, no CPR. That's really the go-to, even more than I've seen people DNR tattooed on their chest. It's really about the hot pink form, I have to say. Okay. So that is with the Advanced Healthcare Directive and the 6 parts. The ones we're most familiar with in spending time is your decision maker, your choices of prolonging and not prolonging life, the details within that. There are many options to consider. Is there any questions on that? Okay. What I'm going to attempt to do right now is I'm going to open up and share my screen with you. So let's see if this works. Many of you might have this. Okay, let me see if I'm sharing it. Share. Okay. I'm sharing my screen with you. You can see some of you, not all of you. Oop. And how many of you have this with you? Okay, great. So I really do. Does anybody not have the, I can't even see everybody anymore, right? Chat. Okay. Let's see here. So what I have in front of me right now, and you have, is it's preparing in a time of COVID-19. So we really went over some of the basics. Once again, for a lot of you, this is probably just validating what you already know and do. This is here to just to confirm what you've already done, but in the time of COVID-19. Decision maker, talk about what matters to you most, the things you should know. A lot of this, I think we've captured in our conversation. So you all have this. What I really want to do is go to the second page. And these are really the questions. I'm going to show this for a second, and then I'm going to go back to just so we can chat a little bit about this. These are the questions, the go-to questions right now is what would be most important to you? What are you most worried about? What is helping you through this difficult time? If you became very sick with COVID-19, would you prefer to stay where you live or go to the hospital? If you choose to go to the hospital, would you want to receive intensive care in the hospital? And list other questions, okay? I'm gonna stop sharing this. I'm gonna go back to chat. Sorry, Devor, I see your question. Is a person with severe pain eligible for palliative care? Depends on what healthcare system they're with. I would say yes, they're eligible, but it really depends on what healthcare system or coverage they have. You have to ask. People sometimes won't bring it up or, try different treatments. So I would ask, do you have a palliative care team? Do you pain management? You can start using some of these words, you start using the terminology, and they might provide a little bit more feedback each time. But I would say, severe pain, yes. Because it's not all about, it's medication, but as you also know, it's about integrative therapies. And for pain, what kind of pain are we really talking about? Hospice and some palliative care deals a lot with all different types of pain, right? I know you're talking about physical pain here, but there's spiritual pain, there's emotional pain. So I just want to acknowledge that because you brought up pain. And that's what hospice is really good at. What is part of their team, depending on what hospice you're with, right? But that's part of the team, is really to get that holistic approach in dealing with pain. I know you meant physical here. And some palliative care systems internally do have social workers, nurses, or chaplains. It's usually a nurse because it's usually about the physical pain. So be aware of that. And I really think a lot of us here on the call, with the work that we're called to do, calling all of us that are working in this community, that'll really help with all those different levels of pain and decision making. And what I say with all that is family dynamics and grief. That's really what, with all this being said and done, is helping with that stuff. Okay. All right. Thanks. Good question. Oh yeah. So Elizabeth gave a great comment. This was really nice. Elizabeth, sorry I have had to get to a client. Thanks, Stefanie. Your last screen reminded me to remind clients to include things in their directive, like ideally with my cat by my side. Thanks again. Pets are so important. And I showed you the Conversation Project COVID-19 piece of paper, but the Prepare to Care, which is based out of UCSF, pets and what to do with pets at this time is like one of the #1 things, like, because who is going to take care of my pet? If my health, that I was talking to another woman that out of everything that was going on with her right now, that was her biggest concern. Who's going to take care of my pet? And so in the other COVID-19 prepare that I'll share with you, that I can share with you, animals was part of it. So that's a big thing. So does Medicare coverage and the additional coverage include palliative? Yes. Coverage is changing all the time, nationally and state by state, around palliative care. I know in Massachusetts and California, there are statewide initiatives, especially when you have Massachusetts General in Massachusetts, there's tons of work going forward in terms of movement about coverage of cost and inclusivity of palliative care. So I know Massachusetts is on it, California, there's tons of bills, it gets overlooked, maybe they're here. Sometimes it's just like we acknowledge palliative care, but is there money behind it? So I don't know where it sits. You have to talk with your own healthcare system, okay? But with telehealth and all of that, I know it's coming out more. If you have COVID-19 and don't go to a hospital or ICU, how long is a person likely to live? Once again, that's a it depends question. It really depends on the person's vulnerabilities, what their own status is. You know, it's like asking how long is somebody going to live on hospice. Sometimes people get better when they're on hospice because they're getting better care, right? So it's really, it depends. Yes, Lynn? Well,
you might not ever have symptoms. You might not ever know you had it because we don't have testing really available.
Yeah, so that's the flip side of it. Yeah.
Or you could have a mild case.
I meant if you needed to go to a hospital, but you chose not to, you basically would die of not being able to breathe, I would imagine.
Yeah, I mean, and then you'd really want to switch over to hospice and get more pain and management relief. Now, finding a hospice system and knowing which ones that are equipped and have been following the NHPCO policies, you know, like some hospices are maybe better equipped, and maybe if they already have protocols in place and they've already asked their staff if they're comfortable with this, because I know that, you know, certain hospices are working with less staff now. So once again, these are all questions of starting sooner than later, or knowing your systems and people that are equipped. I think here in Los Angeles, things are moving forward, but if you want to stay home because you're already sick, the conversation starts. Ideally, you would want to go on hospice sooner than later, because when you go on hospice, the care comes to you. You make sure you have the pulse to find out. And so you have a medical team that you call instead of 911. I mean, that's the whole thing with hospice, right? If you don't want to go back into the hospital, if you don't want to go back into the hospital and you have a terminal or illness, or you have different, we can go into hospice. What are the criteria for hospice? You know, you have to have a comorbidity. You have to have so many acts of daily living that you can't do on your own. You need a doctor's note. So that's if you've gone in and out of the hospital so many times. So there's different requirements, but if that speeds up the conversation, if somebody's saying to you right now, like and they have terminally ill chronics, like now it's like, well, let's just get, if you don't want to go into the hospital, let's get care coming here. It happens to be called hospice. You know, if there was, I'm being very frank with you and kind of, but you know what I'm saying? This is not necessarily how you have it, but if you want medical care, but don't want to go to the hospital, and you have a terminal illness or chronic terminal illness, you might be eligible for a hospice, getting medical care at home, and you won't call 911. Hospice goes wherever you are. It is not a physical place.
Right, but COVID-19 is not a terminal illness necessarily, right?
You know, you have low blood sugar. You've been losing 20 pounds in the last 3 months. There's different things you really have to check. I mean, with what hospitals, it doesn't hurt to ask.
You can request. Yes. You can request an assessment by hospice.
Yes.
Hospice, and they will, at this point in time, they will do it with telemedicine.
Got it. Thank you, Lynn. Yeah.
hopefully a visual. And there will be a nurse there, but the doctor would try to look at your color, your breathing, your activity,
Yeah.
and look at the criteria to make you eligible. They would do all that by telemedicine. The nurse, however, would be on the front lines there with you.
Yeah, thank you for pointing that out. That was something kind of like the protocols of how hospice works.
Right now.
There's an assessment that comes out at, you know, if you request it, it's an assessment. You don't owe them anything. They come out, there's a nurse that comes out and evaluates and says this person is eligible, and then you can go through the process, or then you'll be in their system and they'll follow up with you. So if it's not today, it could be in a week, and this way you're in their system, right? So it's a jump start.
So really hospice is operating with bare bones staff. Everybody's telemedicine except the poor nurse who goes out and does the face-to-face, probably trying to be 6 feet apart with a mask and gloves on.
Yeah. So we have a few minutes because I said we're going to go to 10:15. I just want to showcase some of the resources that I'm talking about. One is Lynn Elkins on the phone with us right now. She is one of the co-founders of End of Life Choices California, which is really a consumer advocacy group to educate on all advanced care end of life conversations, and additionally medical aid in dying, and also will physically be present with people if they want to participate and decide to use medical aid in dying. So it's a really hands-on program that I happen to be proud to be a volunteer as part of. So there's a lot of education and training, and there's volunteers. It's really volunteer driven that are trained to be of support. Okay, so that's one resource.
There's no fee.
There's no fee, right? There's the death doula work and education, which, like I said, family dynamics, grief, doing nuts to bolts with funeral arrangements and detail work is a little bit more, but in terms of education and support, if family already has a really great team in place, End of Life Choices California is a wonderful resource for those first time calls. Conversation Project, National Healthcare Decision Day is part of Conversation Project. They have a lot of amazing tools, how to start the conversation, who will speak for me, very detailed about, and I'm now a Conversation Project champion. Woo woo. I'm on another Facebook group. So these are great resources. And the COVID-19 one, I really like that they do. Compassion and Choices, I used to work for them, and I still work with them. I'm going to be heading off on a call with them in a little bit. This is a great addendum to your advanced healthcare directive. It's much more specific about the care you want or don't want at end of life. It's additional values worksheets, questions, details to go with your advanced healthcare directive. The advanced healthcare directives, there's a general one that was filled out by the National Hospice and Palliative Care Association. It changes by state. It's very thorough. There's another one from Prepare to Care that you can fill out online. That one is created at a 5th grade education level. That was really their gear. They're specific to that. Written in different languages, has videos in there. Let me show you the sheet for that because it just looks different. Oh, here. It's like these colors. It's like be prepared. You know, it's very user friendly. It will take more time, but it's online. Then Stanford has a letter project that's also really interesting and good. And I filled that out. I want you to work with what you already have. I want to see if your healthcare system already has an advanced healthcare directive. So you work within their system, okay? I don't want to give you too much. I'm a paper pusher. That's not my goal. How to have a conversation with your decision maker. How to talk to your doctor. Choosing to prolong or not prolong. The specifics on that, getting more comfortable and familiar with that. What's important to you? some of these resources, just those questions on the COVID-19 page, great questions for you to start. This is my first level session. I'm looking to do this in threes. Intro and more detailed. Advanced healthcare overview, values, legacy, right? To get more specific into different ones. That's what I'm hoping to do with this. What I'm going to offer all of you right now is a 20-minute check-in follow-up with me about where you are with your advanced healthcare directives. How can I coach and work with you to move forward and getting it completed, or what's that next step for you? Okay, so I'll follow up with a doodle. Yay, doodles. It was just setting up a 20-minute time. So I know that you're activated doing your next step, whatever that is, because for everybody, it's something different. Some of them, it might be for you. Some of them might be for a family member you're caring for. Okay. We have a couple more minutes. Is there anything, let's say, the prepare, I'll send links to this. I'll kind of write it out in the, in an email follow-up. Is there, how are we all feeling right now? Put it in the chat box. We lost some people along the way, but that happens. How are you feeling right now? If you want to, we can share verbally. Yes, Lynn.
I hope this is all right, but I just want to share a personal thing. I have an advanced directive. I've done the talking. I talk about it every chance I can with my kids and my husband. But in this time of COVID, I am 78 and my husband, my husband is 85. And we've already made the decision that if we get the virus, we are not going to the hospital. We will stay home. I will call the hospice. I've already planned to call and get the comfort care so we don't have that air hunger. But we're not going to the hospital. We've had a good long life. If we die tomorrow, it's okay. We're not going to die on a ventilator alone. So,
thanks, Lynn. Thank you so much.
Just wanted to say that.
No, I think it needs to be said. I think, and even if us working in this world, we, I ask because it making ourselves vulnerable. I don't know, for you, it may not feel vulnerable to share because this is what but to be vulnerable and put that out there and say, I'm comfortable. You're not, with where you are in that. So I really appreciate that. Does anybody else want to?
I didn't actually realize it was an option.
What?
That you just said was an option. I mean, of course it's an option.
Right.
I never thought of it because you see on the news, everybody goes to the hospital, ventilators.
Right. And I think that's the main question why I wanted Lynn to put that in the chat box. Look, you might not qualify for hospice until you're showing certain symptoms.
Sure.
You fall, and that's a lot for people that we're not going to get into voluntary stopping eating and drinking. You might not qualify, but if people know they don't want to go back to the hospital, you have to prepare. And that's why you have to have the advocates, either volunteer or professionals and or volunteers there to support you through that process. So that's great. Thanks, Jack. Stimulated, better informed, resolved, to be resolved, and you figured out how to use chat. So I think this has been a win-win for you. Natalie, do you have? I know you kind of did this in person with me. So how was it validating, or how was this?
Yeah, this was really helpful. I feel really motivated to get this information out to my network of family and friends, just so I can help practice getting people through the advanced healthcare directive and letting them know that even though we're the age that we're at, it's still an important thing to be doing and planning. I have lots of friends with families and other friends that don't have families, and I think it's important for everyone. So I feel really kind of excited to get out there and kind of help people, which will help me too. Yeah.
Exactly. Like you're feeling a little more ownership, right? Like,
yeah.
Okay, this sounds familiar to me. I hear the speak, I hear, and everybody has a different style. Lynn, who is a nurse practitioner, has definitely a different style than I do. Wisdom
and I'm a lot
style
older.
and everything. So that's great. And Carol, I know you've been kind of, you decided yourself to not be online, which is fine, but I'd love to have your voice in here if you wanted to share anything.
Well, you know, I just started working here at Helping Hands Senior Foundation, so I'm just getting into the healthcare. Thank you. I've got so much information and I've learned so much during this time. So I'm just very thankful about all this new information that I've learned.
Yeah, and I think Senior Helping Hands is great with Sean. Sean's doing amazing work there. So however I can be a mentor and kind of support you and educational resources, as you can see, this is my sweet spot right here of kind of wanting to share and do it. And Sean knows that. I'm sure I think he probably passed on for you to participate. I'm thinking that, I don't know.
Yeah, he did.
That's
he
awesome.
did. But I'm thrilled and thank you so much for all the information.
Yeah. I hope this was digestible. I know for a lot of you it was validated what you already know. I'm glad it's a little bit more inspiring. Thank you. We're going to head off. But I'll keep you posted to do some check-ins, 20-minute check-ins. Okay.
Okay.
Thank you for
Happy
National Healthcare Decision Day.
Yes.
Thank you.
Bye.
Bye.
Thank you.
Thank you very much.